Well, thanks, Mo, for that introduction. And this is one of my favorite lecture places. So welcome. It's good to see a turnout. I haven't given a talk in almost a year and a half, so it's good to be back, as we say. When Mo asked me to give this talk, I was wondering what should I talk about. You know, at some point you think you run out of things to talk about. But the good thing is things change in cardiology all the time. And what I would like to do is to try to put the history of medicine, and it's very important that we understand where we came from so we know where we're going. Those of you who ever visit Santa Monica, if you come to my office, I have a large collection of medical antiques, and I say that's my humility cabinet because there are things there, you know, human placenta extract and worm syrup and things, and you go, what the heck were people thinking? And I'm sure that half of what we do now, in the future, they'll look back and they'll say, what were those people thinking back in 2021? But there are some things that hold true for a long time. So we're going to talk about how things were discovered and then reassessed in terms of their benefit to humanity. And that's why I've called this repurposing drugs in cardiology, because there are many things that you and I use that are of great merit for our patients, but were originally developed for a totally separate cause. These are my disclosures. Many of the things that I talk about today will be pharmaceutical agents, and I do give talks on behalf of some of the pharma companies. So what do I mean by repurpose? It means adapting something for a different purpose. It doesn't mean you may change the dose, for example, of a medicine. It just means that it was originally developed for something, then it was incidentally found to do another purpose, and it could be that that other purpose was actually more useful than the original reason. And we're going to talk, therefore, about 5 different things in cardiology that have changed my universe as a treating physician. We'll talk about medicine that was originally used for pain relief that now is known to prevent heart attacks. We'll talk about a drug that was used initially intended to prevent angina that has become the pivotal drug for heart failure to prevent heart failure deaths. We'll talk about some high blood pressure medicines which have been repurposed specifically for patients with reduced ejection fraction heart failure, and similarly agents that were developed for diabetes and for gout. And many of these actually weren't developed by pharma. They were developed, as I'll show you, by physicians and caregivers like ourselves in the community who made an observation that turned out to change the direction of medicine. I love this quote. This is by an anatomist, a Viennese anatomist named Rokitansky. And Rokitansky, believe it or not, this guy did 70,000 autopsies. And even he was the anatomist of the world, basically, at the time, back in the 1800s. And he said, if you want to learn, you know, you light your torches at the fires of the ancients. So you have to learn from the people who have preceded us, and hopefully they'll help us in our venture and our journeys. So let's go back over 3,000 years ago. And this is the Ebers Papyrus. This was found in antiquity. It's currently in Germany. But this was compiled, we're not sure exactly, but about 1,500 BC. It was found in 1862 in Egypt. And within this 10-meter long document, there are over 800 different pharmacologic recipes. And they didn't have a lot at their disposal. Over 100 of these were castor oil. Just what can you use castor oil for? Because they had castor beans back then. But even this papyrus, over 3,000 years old, has some interesting things in it. Here was one. There's one that says there are 12 different things in there that are supposed to make the heart better. Now remember, nobody even knew what the heart did until William Harvey discovered that 3,000 years later. They didn't know about the circulation, etc. But they specifically had some things in there. And they had things, for example, that nobody would believe now. I don't know what excrement of the gods is, but if you have tremors, maybe you should try that. And here's another one in there, human excrement mixed with yeast of sweet beer and honey. You can try that for wounds. So much like the internet, not everything in the Ebers Papyrus is worth listening to. But there was one that has withstood the test of time, and we're using 3,000 years later. And that was references to using the willow tree. And at that time, it was the bark of the willow tree. Even later, right, 1,000 years later, Hippocrates, the founder of modern medicine, said that you could administer willow leaf tea to ease the pain of childbirth. And of course, even to this day, pain of childbirth is one of the sentinel types of pain in which if you're developing a pain medicine, you would use that to hang your hat on as something that would be useful. So even 3,000 years ago, and then 2,000 years ago, they said, well, there's something in the willow that makes pain less. It took a long time for people to figure this out. And it wasn't until the 1800s when chemistry had advanced enough that people would start saying, okay, what is it about the willow bark? And in 1828, this chemist in Germany discovered there was a substance in the willow called salicin. Turned out within the next 25 years, they figured out that if you altered that, and this is what pharma does, if you ever go to speak to the chemists at the pharmaceutical companies, they're brilliant guys, women too, I shouldn't say guys, who will take a molecule and they'll modify it 2,000 different ways to try to find one that works, or they may in their head say, or using computational science with a computer, saying that if they added a floral group here and a carboxyl group there, they'll make this better, etc. So fooling around with the natural substance, they came up with salicylic acid, which was the original substance, and they added an acetyl group to make acetyl salicylic acid, aspirin, right? That what was there. And it was originally used for rheumatism, right? For pain. Now, the salicylic part, the acetyl part was added to it by this guy, Felix Hoffmann, one of the founders of sort of medicinal chemistry. And indeed, in the late 1800s, Bayer, at that time, was a chemical company, and it patented aspirin, and it called it aspirin. A was for the acetyl, spir was for this plant from which they derived it, related to the willow. And the in was commonly used, just like IX is used by pharmaceutical firms to name their medicine. So aspirin was it was a branded name of a medicine. But if you read the bottom here, and this is true of pharma today, the people who were involved in marketing said, aspirin, it has no potential, right? So they, believe it or not, put it on the shelf and decided they weren't going to promote it because they were promoting the other thing they just invented, right? Down there, you read that. Heroin, right? Which they claimed would not be addictive, and therefore it was better than opiates that people were smoking. Now, the good news is that somebody in Bayer thought second about this and said, okay, let's go ahead and promote aspirin. So here's the main difference, right? Acetylate, there's the original substance on the left. You modify it a little bit, you get aspirin, and hopefully aspirin would then be better tolerated, which it was. That was the main difference between salicylic acid and acetyl salicylic acid, is that it's better tolerated in the GI tract. So that was the key change. But nobody knew how it worked. So even though they had the molecule developed in the 1800s and it was used widely, it was a mystery as to how this worked. And this guy, John Vane, who was later awarded the Nobel Prize for this discovery, figured out that the reason that aspirin worked was related to that acetyl group, and we'll show you here in a second how that works. But what this points out is you can have something that has worked for 3,000 years and not know how it works. And you give medicines every single day that we don't know how they work. So it's beautiful to know how it works because then you might be able to benefit us by changing things, but it's not necessary to know how something works to have it actually work. So if I ask any of you, how does hydrochlorothiazide work? Well, the truth is we don't know. I mean, I know what it does, but we don't know how that translates into lowering blood pressure, for example. So there are many things that we use every day that we don't know. But John Vane figured out that this involved prostaglandin synthesis, and prostaglandins are a relatively new family of chemicals. And that's how it prevented pain, right, by interfering with the pain pathways of prostaglandins. But it didn't actually explain how it worked for what we use it for, a daily aspirin, which is to prevent thrombus. Didn't know how it worked. And figuring out how it worked was left to a general practitioner in Glendale, California, believe it or not. This guy I call the unsung hero of aspirin, Lawrence Craven. I've tried to find more information about him, but sadly it's sort of lost to history. So in 1948, right, 1948, way before the American Heart Association, the American College of Cardiology, and the general community recommended aspirin, he wrote that he recommended an aspirin a day to reduce future heart attacks. And that was based on his observation of his patients. And funny thing was, he was a GP, and he was giving aspirin to prevent pain of tonsillectomy in kids. And it turned out when he gave them aspirin, he noticed that there was more bleeding, and he wrote this up. He said there's something in aspirin that promotes bleeding, and that maybe we can use this to prevent clotting, and therefore he said, I'm going to use it in my patients to prevent heart attacks. And this was his advice, 1948, give an aspirin a day for men between the ages of 45 and 65, especially if they are overweight and sedentary. Not bad advice, way ahead of general medicine. He also made that recommendation for anybody who had recovered from a heart attack, right? So already the concept of primary prevention, secondary prevention, and the primary part is debatable currently. We'll talk in a second about that. But this was based purely on not a clinical trial. It was based on his observation of 8,000 patients in his clinical practice. And he published this, but notice where he published it. The Mississippi Valley Medical Journal. My subscription lapsed, so I didn't read that. But that's part of the problem. Part of the problem is that if you and I made an observation in our last 10,000 patients, where are you going to get that published? Do you think the New England Journal of Medicine is going to publish an article by Lawrence Craven, a general practitioner in Glendale, California, based on observation? So nobody knew about this, right? He did, but nobody listened. That's part of the problem with medicine today. He died in 1957, unfortunately, of an MI. I don't know whether he was taking aspirin at the time, but he died of an MI. So that was back in the 1940s. And here's the first clinical trial ever to take that advice. So here it is more than 25 years later. And this is a small clinical trial in the British Medical Journal in 1974. If you look at the data here on your right, it showed that aspirin actually worked, but because the trial was too small, it didn't reach statistical significance. Now, you look at those curves, to me, it looks like aspirin's benefiting people. But the article said, aspirin doesn't work because it didn't reach a p-value of less than 0.05. Right? So they rejected aspirin. Now let's get back to say, how does aspirin work? So John Vane knew that it was involved with prostaglandin synthesis for the pain relief part of it, but that didn't explain fully how it worked as a minor blood thinner. Well, it turned out the way it works is depicted on this particular slide. This is a cartoon of a platelet, and it turns out there are many vulnerable parts of a platelet that you and I can attack to prevent platelets from agglomerating and causing the initial thrombus. So there are many, and you use this every day. If you give clopidogrel or any other antiplatelet agent or aspirin, this is the target, the platelet. And maybe the platelet precursor, the megakaryocyte. That's still somewhat controversial. Within this, in the green area, is where aspirin works. And it's a particular enzyme, cyclooxygenase, the same enzyme that's attacked by all the non-steroidal anti-inflammatory drugs, whether it's celecoxib or whether it's ibuprofen or naproxen. This is the enzyme that is attacked, and therefore when you give those substances, the normal function of the platelet is interfered with. So here's a molecular model of the cyclooxygenase. It's actually a dimer which comes together, and it's all been worked out. It's really beautiful science that what happens is the catalytic site, and the catalytic site, whoops, let me go back here. The catalytic site is a cleft, and if you interfere with that cleft, you can prevent this enzyme from doing its job. And it turns out that's what aspirin does. On the right half here, in those red arrows, I've indicated what aspirin does. It donates its acetyl group, and it hence permanently paralyzes that platelet so that that platelet can no longer do its job to cause a clot. And that's the difference between giving naproxen, which interferes with this enzyme but doesn't covalently alter it, and aspirin, which does. So if you give a baby aspirin right now, aspirin has a very short half-life. But if you give it, and you give non-coated, don't give coated aspirin, it doesn't work in a quarter of people because it's not absorbable. If you give non-coated aspirin, within 15 minutes, all the platelets circulating at that instant are paralyzed for the rest of their 10-day life, which is why aspirin has a lingering effect, right? If you give ibuprofen or naproxen, you block this, but as soon as the drug's gone, the platelet goes back to its usual. And that's why we don't use ibuprofen or naproxen or Celebrex as preventers of clots. And of course, it's only the clot part. Here in this depiction, left to right over decades, the development of atherosclerosis and eventually an erupted plaque, which causes potentially a clot to form, and that's where aspirin works. So does aspirin help prevent heart attacks and TIAs? And the answer is yes, in appropriate people. So the first trial was not trial, but 1948, right? His publication saying use aspirin, the first trial was 74. It was statistically inconclusive, and hence it wasn't in guidelines. Guidelines are guidelines, they're not rules, but a lot of people follow guidelines, didn't make it into the guidelines. But eventually enough aspirin tablets were done, and this is a meta-analysis of aspirin studies using variable preparations. Now, one of the problems with aspirin is they didn't realize that non-coded versus coded made a difference. So some of the clinical trials are besmirched by the fact that they use enteric-coated aspirin on the philosophy that it was safer. Enteric-coated aspirin is not safer. The reason enteric-coated aspirin is well tolerated is because it doesn't get absorbed. So what I tell my patients is if I gave you an aspirin coated in stainless steel, it'd be terrific. You wouldn't have any stomach upset. You also would have no benefit, right? So enteric-coated aspirin is safer only because it doesn't get absorbed and hence doesn't have the systemic effect. It's not the stomach effect. It's the systemic effect that causes GI bleeding. Right? But nonetheless, you can see that there's a benefit if you look. And hence, aspirin subsequently was indeed put into the guidelines saying that appropriate people with known atherosclerosis, particularly those with events, should be put on aspirin, and even a low dose works. So it works by lowering heart attack and death by about 20%, but only in appropriate patients, right? If you said, let's do an aspirin trial and we're going to go to the local high school and we're going to give 10,000 high school kids aspirin versus placebo, you'd show no benefit. Right? All you show would be bleeding in 1 or 2% of those poor kids. So you have to use it in appropriate patients. Use non-coded to ensure absorption. 81 milligrams is sufficient. The lowest dose that works is somewhere around 50. So if somebody really wants to go down, they could take a half of a baby aspirin. It seems kind of preposterous, but that could work. So that's old news, right? That goes back 3,000 years. And if you looked, I said something old, something borrowed and blue, et cetera. So what was borrowed when we repurpose a medicine? Well, here's something. This is a picture of a Brazilian pit viper. You heard that I spent time in the Amazon. The tribe with which I worked were deadly afraid of snakes because there's so many venomous snakes in the Amazon. And they knew that if they got bitten, there was nothing that would help them. They had their local shaman, and if you had a bellyache, you went to the shaman and he danced around and gave you herbs, and then you'd pay him with a cow or whatever. But if you got bitten by a snake, the shaman would throw his or her hands up and say, sorry, we don't have anything to give you. And so this is a Brazilian pit viper, and it was noticed that field workers in Brazil, when they were bitten by this pit viper, would go into shock and die of hypotension. So people said, gee, that's interesting. Maybe there's something in the viper's venom that lowers blood pressure, and maybe, just maybe, we can use that in lower doses, hopefully, to avert complications of high blood pressure in our patients. And it was John Vane, the same guy who discovered how aspirin worked, that was the pivotal observer of this. He had read from some of his scientific colleagues that there were substances in the blood that maintain blood pressure. And he said we should look at those and see whether the viper's venom interferes with these substances. So even though he won the Nobel Prize for aspirin, he was also the person that was the fundamental discoverer of this, which turned out to be ACE inhibitors. Right? So this particular viper has a substance in its venom which interferes with the normal regulation of blood pressure. And it does so by interfering with this complex pathway. You and I have substances to raise blood pressure, and you and I have intrinsic substances to lower blood pressure. And there's a constant dynamic there, which can be interfered with by bacteria or by food or other things. But it turns out one of these particular places is vulnerable, and many animals in the animal kingdom have discovered this and attack that, right? And that's the renin-angiotensin system, as this Brazilian pit viper did. Now, once he discovered that that was the vulnerable place, pharma went to work and they came up with the first of the ACE inhibitors, Captopril. Now, to put this in perspective, we did the original Captopril trials at the Brigham when I was there. And we were so fearful of this because of the vipers causing people to die that to start Captopril, you had to bring somebody into the hospital and admit them to the hospital, right? And we give them 1 milligram, then we give them 2 milligrams, you know. The problem is that to really lower blood pressure, when the drug first came out, Captopril is not used much anymore, but if you remember the dose, it was typically ended up being about 25 milligrams. In the trials, initial trials, the phase 1 trials, they were giving 400 to 800 milligrams of Captopril, and people went into shock. So that's why we had to admit them to the hospital. But once they figured out the dose of 25 milligrams, it said, okay, now this works. We've here used this viper's venom to come up with a substance that would actually help. But it's not the greatest blood pressure reducer. And of course, there are over a dozen ACE inhibitors. The most commonly used in the United States is lisinopril. So let's see how lisinopril stacks up against others, because commonly many of you will reach for an ACE inhibitor, but we have clinical trials that would suggest there may be other drugs that are actually better for blood pressure. And then it turns out the ACE inhibitors had a specific role, but not in hypertension. It really ended up being in heart failure. So let's look at the data. Here's the largest blood pressure trial ever done, sponsored by your federal government. 42,000 patients randomly assigned to one of 4 different drugs for hypertension. This remains the largest hypertension trial and will remain the largest hypertension trial ever done. They chose 4 drugs to randomly assign people to. Chlorothalidone, of course, which is a thiazide-type diuretic. It's not really a thiazide, but it's a thiazide-type diuretic. Originally, by the way, that was developed to be an antibiotic. It's related to a sulfa, and so they took sulfa drugs and they modified them, and it turned out one of the modifications didn't do squat for antibiosis, but it lowered people's blood pressures. That's how they got chlorothalidone. Lisinopril, the ACE inhibitor derivative of captopril, amlodipine, of course, the calcium channel blocker, dihydropyridine calcium channel blocker, and doxazosin, the alpha blocker. Now, the data I'm going to show you don't include doxazosin, right? Even though all 4 of these drugs lower blood pressure, doxazosin turned out to be the weakest of the bunch in terms of clinical benefit, and it was dropped out. So right there, it tells you that not all blood pressure drug reducers are the same. But here's what the results of 42,000 patients randomly assigned to these. Green is lisinopril, red is amlodipine, and yellow is chlorothalidone. So if you look at the left numbers, which is systolic blood pressure, you notice right off the bat at good doses, and these are all doses you and I use every day in our patients, that if you just went by systolic blood pressure with a high degree of statistical significance, chlorothalidone easily beats its competition for blood pressure reduction. Doesn't mean it's necessarily better. I'll show you in a minute the outcomes. But for blood pressure reduction, the ACE inhibitor, at least at the doses we use, is not as good as either the calcium channel blocker or the thiazide-type diuretic. If you look at outcomes, here's the end result of the trial. Now, here's one problem with most of these trials. Most of these clinical trials were under the belief that if you lowered blood pressure, you would lower heart attacks. Turns out there's a little truth in that, but not much. If you want to lower an event rate, it's better to look at stroke, heart failure, and kidney failure in terms of blood pressure reduction than it is to look at heart attacks. So this is a little bit besmirched by that. But nonetheless, if you look at the composite endpoint here, focusing on cardiovascular events, most of which are heart attacks, the drugs were the same. So right away, this tells you there's some interesting facts here. Number 1, there's a difference in blood pressure reducing drugs in terms of blood pressure reduction. Number 2, that didn't seem to make a difference for heart attacks. Whether you lowered it by an extra 5 points made no difference in 42,000 patients randomly assigned over an average follow-up of almost 5 years. So these are huge data that would tell us there's more than just blood pressure reduction in terms of reducing cardiac events. But what it did show was the other events did correlate with blood pressure reduction. So for example, here, amlodipine and chlorothalidone were superior to lisinopril for preventing strokes. Even though they were different in blood pressure, they weren't different in heart attack. They were different in strokes. Not a big difference in cardiac events. But what it turned out was the ACE inhibitor had a unique benefit not shared by amlodipine or chlorothalidone in terms of preventing events in people that already had heart failure. Now, that was totally unexpected. Nobody even was looking at it. And it wasn't until they started doing trials and they go, gee, there are these people, they seem to be doing better. And the second ACE inhibitor on the block, enalapril, had nowhere to go, so the company that made it said, well, let's explore people with this problem of weak hearts, this reduced ejection fraction heart failure. And they said, let's, instead of using it as a blood pressure drug, let's give it to people, most of whom don't have high blood pressure. In fact, if you have an ejection fraction that's low, like depicted on this cartoon, your average blood pressure is around 110. Well, we don't give hypertension drugs to people with a blood pressure of 110. Well, we don't to lower blood pressure. but we might if we can lower events. So enalapril was used because it was not felt to have a market. Again, I use that term market because that drives a lot of pharma's decisions. It's a business after all. And here, enalapril versus no enalapril clearly showed a benefit in people with reduced ejection heart failure. And this is the hardest endpoint, the most valid, which is are you alive or are you dead, right? This is total mortality. And it clearly had a benefit. So this turned out to be the unique place initially for ACE inhibitors. Not for blood pressure reduction. We now have over 100 different agents that lower blood pressure, but for people with reduced ejection fraction heart failure. And the data were overwhelming that this group, for reasons that weren't totally clear, benefit uniquely from this class of drugs. And here are some of those studies. And the green are people that had already reduced ejection fraction. In the right are people that had a heart attack. And it turns out that ACE inhibitors are useful after a heart attack, not so much if your EF is normal. If you came in tomorrow to the hospital and your troponin's 2 and you had a non-ST elevation MI and Mo opens the artery and puts a stent in, that person does not do better, it turns out, with ACE inhibitors. But if somebody had a low ejection fraction, you can see the overall reduction in death was around 20%. So that's similar to the benefit of aspirin, and it turns out they're additive in people that have the right diseases. Now, that was up until about a decade ago. And science advances, right? So lisinopril was terrific, so was benazepril and the other prils, the other ACE inhibitors. But now they've been superseded because there's a drug here, a combination drug using an angiotensin receptor blocker, valsartan, which is the old Diovan, with a new substance, sacubitril, which is an enzyme inhibitor. And when you put those together, you beat handily the ACE inhibitor. So even though ACE inhibitors for 20 years are cornerstones of therapy for reduced ejection fraction heart failure, they have now been superseded by this particular sacubitril valsartan, which is called Entresto. Because head-to-head, it's better, and it's better right out of the gate. So I run a heart failure program. I oversee heart failure for 50 hospitals. Do we recommend an ACE inhibitor? Sure, but if you have to recommend something, you'd recommend this combination because it is simply better. So ACE inhibitors originally came from the snake, used for hypertension, still can be used for hypertension. You can use them for kidney protection, although even that now has been superseded by new drugs. But for heart failure, we've switched to the angiotensin receptor blocker combination. So still useful, but eclipsed by better drugs. Now what about lowering heart rate? Here's another guy, another Nobel laureate. I don't usually talk about lots of Nobel laureates, but here's one. And this guy is James Black, a Brit, and he was a physician who won the Nobel Prize in 1988. And that's because he invented something. What I've shown you so far exists in nature. A lot of the drugs you and I use, there's something out there. For example, there are calcium channel blockers in snails in the ocean. You have ACE inhibitors in you, so does the snake, actually. And then, of course, the willow makes the precursor to aspirin. But as best we know, there are no beta blockers. This is an imaginatory somebody saying, hey, I have an idea. And he had an idea. His dad died of a heart attack and had angina. And when he was in medical school, he said, well, I know I can at least treat angina, I think, if we lower heart rate. So how can I lower heart rate? And he had this brilliant concept that adrenaline is circulating, epinephrine, and norepinephrine, these other substances, and they have to somehow tell the cell to speed up. How does it do that? In his mind, he said there must be a receptor. Now, the beta receptor had not been discovered yet, but he said it must work through a receptor, so maybe if I take the adrenaline and I modify it, maybe I can make something that will sit on the receptor but not stimulate the receptor. It'll sit there and just act like an umbrella in a rainstorm, and it'll prevent that receptor from being stimulated. So he said, let's take adrenaline and let's modify it and see if we can find something that binds to the receptor but doesn't stimulate the heart. And that was the pivotal moment in receptor biology, because lots of things you and I use now block receptors. And these had not been, they chemically, Alquist had said, there's got to be some interaction, but they hadn't actually developed them. Now it turns out to be, I spent years as a protein chemist doing receptor intermediary G protein research, and I'll tell you it's way more complicated than even this Nobel laureate thought about. But that was the pivotal observation. So he, in fact, found they did many, many different substances, but the first one that was actually tolerable and worked was propranolol. And of course, it's still around today. You may have patients that are on propranolol. And look at this was patented in 1962. So it's almost 60 years ago that this was used. And it was very successful at lowering heart rate and as a consequence of that, preventing angina. Later, it was found to lower blood pressure, although that is not the best use of beta blockers. The drugs that I've shown you a moment ago are superior to beta blockers for lowering blood pressure because the beta blocker blood pressure reducing effect is an indirect one through a different enzyme pathway. It's not as good as amlodipine or chlorothalidone or even the ACE inhibitors, the ARBs, but this is a really good class of drugs to lower heart rate. However, other than angina and supraventricular tachycardia, the role now for beta blockers is totally switched because of an observation, again, made by a Swedish doctor who had somebody who had low ejection fraction heart failure and was a tachycardic, and he didn't know what to do, so he literally said, I don't know what to, and he gave a beta blocker. And miraculously, the patient improved. I was telling my wife, Sally, yesterday that I had a patient with an EF of 15%, a heart rate of 103, and all I did was lower the heart rate, the EF went up to 50%. And I'll show you why that occurs in a minute. But that's what this observation back in the 1970s were. And when he first came out with that concept and said, hey guys, how about if we lower heart rate in people with low ejection fraction heart failure, maybe we'll benefit them. And he was roundly castigated because the thinking then, 1978, was that beta blockers should be avoided in two things, heart failure and asthma. Okay, maybe I'll give you asthma, although we could argue about that. But heart failure? No. And this is why the authorities said, don't give beta blockers to heart failure, because, gosh, those patients are so sick, they're critically dependent on heart rate to maintain cardiac output. And if you give them a beta blocker, you might put them into cardiogenic shock. That was the thinking in 1978. Well, a month ago, I went to Wikipedia. Again, your patient's doing this every day, going to Dr. Google instead of you and trying to decide on what they're going to want. And it says in Wikipedia a month ago, beta blockers should not be used in those with an already slow heart rate and most of those with heart failure. Wrong, wrong, wrong. And that's still out there. Really unbelievable. Here's why that observation was fundamentally wrong, that beta blockers shouldn't be used in patients with reduced ejection heart failure. So in red is your heart. Hopefully you don't have heart failure. So in the normal heart, there's a force-frequency relationship, which means the faster the heart beats, the more powerfully it beats. So left to right is heart rate. The vertical axis is the strength of the heartbeat. And notice that for your heart, when you go from a heart rate of 60 to 90 to 120 to 150, there's a dramatic increase in the inotropy, the contraction of the heart, until you get too fast when the heart starts to fail. So if you get up to 180, 200, and you maintain the heart there, the heart will struggle. Right? But in green is a heart failure patient who's just had a heart transplant. You take that heart out of the patient's body, and then you subject it in vitro to, or ex vivo, to testing. And what you see is the biology of a normal heart does not exist in the biology of a struggling, failing heart. In those hearts, the faster you go, the weaker the heart gets. And that's because of molecular mechanisms that the heart changes itself. If your heart is weak, it goes into an almost hibernation phase. It tries to protect itself. And it does that by saying, if the heart goes faster, I'm going to get weaker to preserve my energy. So notice that the heart inotropy goes down, down, down. If you take the explanted, dilated cardiomyopathy, heart transplanted patient's heart out, and you take a normal heart in muscle strips at a heart rate of 20, they are identical. So that led to this brilliant observation that if we slow the heart, you'll go up that green curve, and maybe, in fact, you'll improve, not decrease, the cardiac's systolic function. And indeed, that's the case. In a big trial, looking at randomization, in this case, metoprolol, of patients with EF starting at 25%. And if you give them placebo, their EF remains 25%. If you give them a beta blocker, look what happens on the far right of this curve. The ejection fraction goes up. And it turns out beta blockers remain the best way to improve ejection fraction pharmacologically in patients with reduced EF heart failure. The average increase is 9 ejection fraction points, which, believe me, in the heart failure world is enormous, right? ACE inhibitors gave a 1 to 2% increase. Beta blockers, it's 9%. That has not been superseded, by the way, by any pharmacologic therapy. And that's why beta blockers now are the cornerstones, the most important drugs for patients with reduced ejection fraction heart failure. And does that translate just into a number in an echo lab, or does that translate into benefit? It clearly translates into benefit. Here are 4 trials looking at beta blockers, 3 of which have been, quote, approved and are recommended. Metoprolol in its long-acting form, which is metoprolol succinate, carvedilol, and bisoprolol. Those are the 3 of these 4 dots in the lower. And what you see is, and again, this is death. Mortality is reduced 35%. That's twice the aspirin reduction. It's twice what lisinopril achieved. And again, no modern drug has exceeded this. So beta blockers remain, not for angina, they're good for that, or SVT, they're okay. Not for blood pressure, we have better drugs, but for heart failure, this is by far the most important, so long as your ejection fraction is below normal, right? There's the reduction, 35%. Now, how does this work? We believe it's purely related to the heart rate effect of lowering the beta blockers, and the reason is exemplified by this particular observation. We don't know yet for sure, because there are nuances here that I don't have time to go into. But if you take a very large trial and ask a simple question, these are heart rates, by the way, developed on an EKG, not from what your MA or you take when somebody walks into the office, and there are important differences there. But if you just do a data analysis and you look at what's the heart rate on a 12-lead EKG with a person lying there calmly, in green, if the heart rate is between 75 and 80, in the next color down, 70 to 75, yellow is 65 to, and what you see is as the heart rate goes down, the death rate goes down also. And in fact, if you get the heart rate to 60, you lower the death rate by half almost compared to a heart rate of 74. Now, I would posit that if you had a heart failure patient walk into your office tomorrow, Monday, and their heart rate was 74, you wouldn't bat an eye, right? 74, that's perfectly fine. It isn't if you have an ejection fraction that's low, because you'll do way better at a heart rate of 60 or 65. And that's why running a heart failure program, the most important thing I do is try to get the heart rate down, get the heart rate down, get the heart rate down. Now, this doesn't apply if you're in fibrillation, because there the heart rate's all over the map. This is in people in sinus rhythm. Also has some repercussions for people with pacemakers in place, because do we want to set the backup heart rate at 50 or 60 or 70, depends, this kind of thing. But for simple patients, 3/4 of the patients with reduced EF heart failure are in normal rhythm. We have to get their heart rate down. This is the single most important thing we can do to reduce their mortality. So resting heart rate should be 60. That's our goal. Whether we measure it by Fitbit, by an Apple Watch, by EKG, by Holter, by vital signs, remains unknown. The data I showed you were based on an EKG. It may be different if your patient is monitoring their heart rate at home. I'm going to move on to diabetes therapy. You're going to hear a lot more from Dr. Wong about diabetes therapies later this morning. But I want to make some observations. This is a list of some, not even all, of the diabetes. Do you realize there are 10 major classes of diabetes therapies? This is left to right as hemoglobin A1C reduction. For all these different drugs, this is ridiculous, right? People had this focus that the treatment of diabetes should focus on control of their hyperglycemia. Well, people don't normally die from hyperglycemia. Yes, you can die of DKA, and yes, you can die of hypoglycemia, more problematic maybe than hyper, and yes, you have microvascular disease, etc. But what do diabetics die from, right? They die from cardiovascular events. Yes, some die of gangrene, etc., but most of them die of cardiac events. They double their risk of heart attack and stroke, etc. So the focus on glucose has kind of missed the boat a little bit here. So all of these drugs, they wouldn't get approved by the FDA unless they lowered blood sugar, but most don't actually prevent what you and I are trying to do, which is prevent adverse premature events and make somebody's life longer and better, right? And that's the rub against diabetes drugs. In fact, the FDA noticed this and 15 years ago decided, hey, we're not going to allow any diabetes drug to come out unless they do an outcomes trial, because maybe you'll make the blood test better, but we want to make patients better, not the blood test better. So, the newer drugs came out, and they were subject to testing that older drugs weren't. As an example, all of you have patients or loved ones, or maybe yourself, on metformin. Okay? What are the data on metformin and death reduction? Anybody know? Was there ever a trial pitting metformin against placebo for death? And the answer is no. Metformin might actually have a mortality benefit. It may take 10 years to show. We're not even sure how metformin works. The latest data are that it affects the biota of the gut and it increases GLP agonist levels and things. So we're still in a quandary about that. But we do now have mortality data in selected patients on the newest drugs, and I'm going to talk about one of those now, which is the Sglt2 inhibitor class of drugs. So it turns out, in red are your blood vessels, making the proto-urine here, and because glucose is such a small molecule, it makes it through the glomerulus into the urine. Not really into the final urine product, but into the proto-urine, which is then, in the tubule, readjusted according to the body's needs. Most of us, if glucose is filtered, which I can assure you it is, the glucose is reabsorbed because in a time 100,000 years ago when we were calorie deficient, and if you look around the room, most of us are no longer calorie deficient, but we were years ago. And it turns out that saving glucose was important. So we have pathways, protein pathways, to reabsorb glucose, and it turns out that same pathway reabsorbs sodium, and that's why it's called the sodium glucose transport, because it absorbs both from the initial filtrate before the final urine is produced. Well, it turns out that that protein is blockable, right? If you block that protein, what will happen is the sugar that's filtered will then be excreted into the urine. It won't be reabsorbed. Same thing with some of the sodium. Now, it turns out when that drug was subject to these outcomes trials, and there are a host of these drugs, right? Some of which are, they're all the flozin drugs, canagliflozin, dapagliflozin, empagliflozin, and there are others out there as well. But to the left here, the drugs are better. To the right, they're worse. And of course, the line of unity, the vertical axis. And what you see across the board is for hard outcomes, heart attack, death from a cardiovascular cause, even for some of these total mortality, all of them are to the left. And for the first time, the very first time in history, we had drugs that improved blood sugar, but to my mind, more importantly, actually prevented premature death and morbid events like heart attack. And people go, that's really interesting. The interesting thing about this is that if you pitted it against anything else that lowered blood sugar, it was unique for this and the other new class that you'll hear from Dr. Wong about at preventing cardiovascular events. So it wasn't driven by what you and I measure in terms of fasting glucose, postprandial glucose, hemoglobin A1C. It wasn't driven by that. It's some other effect of this particular drug. And in fact, when you then dive into the data more, it's even more interesting because to the left is better, and what you see for the Sglt2 inhibitors is there are two unique things that seem to make that class of drugs stand out. One is, just by happenstance, heart failure, both in terms of hospitalization, that's HHF, or heart failure death, were dramatically better in people who were randomly assigned to get an Sglt2 inhibitor. And this was true of all three initial major drugs that were being looked at. The kidney outcome, and now it turns out that's not related to glycosuria because they now have clinical trials with GFRs down to 15, which show that even if you don't spill glucose into your urine, your kidneys are protected by this class of drugs. So it has nothing to do with the fact you're eliminating glucose and sodium in your urine. All-cause death, 15% reduction. The first class of drugs to show this. As I said, do you think sulfonylureas have a death reduction? No. Right? Metformin? Probably not. This, definitely. So why is that the case? Well, I will tell you right now, we're not sure why that's the case. One beauty of medicine, and I alluded to this earlier, is you can have a medicine that works like a charm, you don't have a clue how it works, right? So we know that Sglt2 inhibitor classes lower sugar by promoting glycosuria. We do not know how they prevent heart failure deaths and heart failure hospital stays. I'll give you some insight maybe into that in a minute. But when people saw this, they go, gee, maybe the Sglt2 inhibitors should be used as heart failure drugs rather than diabetes drugs. So a big trial was mounted with about 5,000 patients, asking if you had somebody with reduced ejection fraction heart failure who didn't have diabetes, they just had dilated cardiomyopathy, would they be better off on an SGLT2 inhibitor or not? And what you see in red is conventional therapy, meaning the people are on beta blockers and spironolactone, an ACE inhibitor or Entresto, and they're on those types of drugs, versus those drugs plus the SGLT2 inhibitor. And what you see is a 26% reduction in death or hospitalization. And this is huge, because even though we have really good therapies, I mentioned the beta blockers, just a moment ago, spironolactone, we talked about ACE inhibitors and Entresto. On top of those, all good therapies, we now have a fourth class. And right now, the heart failure community is convinced that if you have a reduced ejection fraction, that there are 4 drugs that you should be on. The beta blockers that I mentioned, spironolactone or eplerenone as a mineralocorticoid receptor antagonist, one of the renin-angiotensin modulators, preferably Entresto, and an SGLT2 inhibitor, even though we don't know how the SGLT2 inhibitors exactly prevent death and morbid events in heart failure. They really, really work. So my prediction is that already in the heart failure community, this is the standard. And in my particular Santa Monica thing, this is our metric for heart failure that we're using this year, is how many patients go on an SGLT2 inhibitor, because it's the most important advance in a decade for patients with heart failure. It will also, however, emerge that this will be the most important way of preserving kidneys in people with kidney dysfunction, like nephrosclerosis, for example. And that will be true even in non-diabetics. So in the heart failure world, we now view the SGLT2 inhibitors as heart failure drugs and kidney preservation drugs that happen to lower blood sugar also, right? The good news about these drugs is they don't lower blood sugar, importantly, in non-diabetics. The reason they probably work is it turns out the SGLT2 protein exists in your heart, as does the SGLT1. And when you interfere with that, you alter the energetics of the heart. So all the heart failure medicines that we typically use have a lag time, 6 weeks, 12 weeks, 3 months before you start seeing benefit. These drugs benefit people in the first week. And that tells you right out of the gate that it's not a diuretic and it's something to do with making the heart better. So in normal people, on the top is high sugar diabetic, you're going to spill sugar. On the lower one, if your blood sugar is normal and you give somebody an SGLT2 inhibitor, you really don't spill much sugar. So you don't have to worry about making somebody hypoglycemic. Now, lastly, about the SGLT2s. There are a family of receptors. The SGLT2 receptor is one of them, but there's also an SGLT1 receptor. That's the gut transport protein to allow glucose to come in from the gut into your body. And we now have the ability to block that. So if you block sugar uptake from the gut, you benefit people as well. And here's the first of those. This drug, sotagliflozin, blocks both SGLT1 and 2, and it turns out the SGLT1 receptor is in the heart in addition to the gut. So it may well be, and look at where these curves diverge. I mean, this is just unbelievable, running heart failure trials for years, that in the first week, the curves diverge in favor. We have never seen that in a heart failure trial. So these are really important drugs. We're still figuring out in whom to use them, etc. Now, SGLT2 inhibitors exist in nature, turns out, right? We thought they were it turns out we didn't invent them. They're found in apples, right? This is the substance that's in apple that is an SGLT2 inhibitor. And it was found in 1835, this substance was described, and it was subsequently found that this substance lowered blood sugar. It's why if you give apples to diabetics, their blood sugar goes down. Turns out you're giving them an SGLT2 inhibitor. So maybe an apple a day will keep diabetes away. Who knows? Maybe. So my prediction is that SGLT2 inhibitors will become the standard of care in treating reduced ejection fraction heart failure. It will be the standard of care in preventing progression of kidney dysfunction, even in non-diabetics, and await further data because there are many trials currently underway using SGLT1 inhibitor as well as SGLT2. So lastly, I want to talk about gout, an ancient disease. Hopefully your foot doesn't look like that gouty foot on the right. Going back to the Ebers Papyrus. So willow bark was there, that was aspirin. Well, it turns out that they also mentioned a plant, the autumn crocus. And it was described to treat what they called rheumatism and swelling. And of course, gout wasn't known about back then, but if you had a swollen big toe, they said use the autumn crocus. So here is the autumn crocus. It's described in antiquity throughout the next 3,000 years to treat gout. And interestingly, in 1763, it was also recommended to treat what they called dropsy. That's the old term for edema. So they were using it for heart failure in 1763. And an interesting note from the history is that Ben Franklin, who had gout, imported this plant from Europe, from Paris where he was, and brought it to North America so he could grow his own supply, kind of like the marijuana farmers around here, I think, but growing your own supply. So it turned out that what was it in this plant that made people that had rheumatism and swollen and gout better? So the active ingredient was named colchicine back in 1833. And the first clinical trial took 130 years later, right? 1961 in the Annals of Internal Medicine, but it wasn't randomized. So it wasn't until 1987 that the very first trial did colchicine work. And the funny thing is, everybody in this audience who was trained prior to 1987 used colchicine for gout, but it hadn't been tested. And we just knew it worked, right? Hadn't been tested. So patients with gout, turns out, have a higher risk of heart attack, much like diabetics do. Turns out that if you look at gout patients, if you have a gout patient who's taking colchicine, their risk of heart attack is lower than other gout patients not taking colchicine. And that this benefit was only manifest while people were taking colchicine. And that then led to this concept that maybe not only is colchicine good to prevent gouty attacks, but maybe there's something about colchicine that helps prevent cardiac events, right? A relatively new concept. So that was actually put to the test, and there are now several large trials. Here's one. After a heart attack, randomly assign people to go home on colchicine or not. They all got their usual stents and aspirin, and et cetera, et cetera. And in red is no colchicine, as blue is colchicine. And you can see in a patient trial with 4,700 patients, this Colcott trial, that if you randomly assign people to colchicine, they did better than people given standard of care without colchicine. So the first of the randomized trial that showed, gee, maybe in fact this observation held merit. Here's another trial, a larger trial, and this actually asked the endpoint, not if you had a heart attack, but what if you just had coronary disease? What if you saw Mo and had 2 stents put in? Should that person be on colchicine? Look at the blue versus the red. These are dramatically different numbers, and you can see there's a 31% reduction in cardiac events just giving somebody a single pill of colchicine every day. And the curves diverge very early. Now, we're not sure exactly, even though this has now been replicated, it's very highly statistically significant. We're not sure exactly how it works. But in red are microtubules. These are the little structural arrays in your cells, and we know that how colchicine works in gout is by preventing microtubular structures from arranging themselves. And hence, if you do that, it's an anti-inflammatory drug, which is why people so dramatically improve with gout when you give them right out of the gate an anti-inflammatory drug like colchicine. So the thinking here is that you avert the inflammatory aspect of coronary disease, and that these microtubular arrays are interfered with by colchicine. So anti-inflammatory medicines were tried. It turned out methotrexate didn't work to prevent heart attacks. There was an interleukin drug that worked, but it was way too expensive. Aspirin, some people said, well, maybe that's an anti-inflammatory. It turns out at the dose we're talking, it's only the antiplatelet. But this is the first of the available, inexpensive, relatively, drugs that can be used to prevent heart attacks. So we're just not sure yet, should it be 0.6 a day, which is the dose you and I mostly give, 0.5, which is the dose in Europe. Will 0.3 work? The drug's not cheap right now because of weird rules that the federal government promulgated. But that is another advance that's occurred in the last year. So in summary, what can I say in 2021? This is the something blue part of the old and new. My supposition is many cardiac patients are being inadequately treated. And by that, I don't mean pacemakers and stents. I mean drugs, right, as well as lifestyle. Medications make an enormous difference. If you want to make a heart failure patient better, The best way isn't to send them to the transplant team. The best way initially is to use the pharmacology that I've mentioned already. And it's not rocket science. It's actually much harder than rocket science. Rocket science is very simple. It's math, man. You just put in a few equations. All of you know that when the 87-year-old demented lady comes in, there's no algorithm that's going to help you, right? So this is where the art of medicine comes in. It's much harder than just math. But with appropriate aggressive medications, I can assure you many lives can be saved, and I thank you for your attention. I look forward to your questions.